guess the topic of the roundtable, it's relevant and will continue, actually, the discussion we just started, actually. Yeah, exactly. Professor Yokote, please.
Thank you. We've already had a very hot discussion autonomously, so probably there's no need for moderator, but Alberto and I will make a wrap-up roundtable discussion. And for our theme is, just as we made discussion, that TG-rich lipoprotein remnants, what is their relevance to residual macrovascular risk when LDL cholesterol low? So as Aruna showed the prominent data, and then high intensity statin is enough? There are any additional needs for sparm alpha or TG-rich lipoprotein reduction? Can I start by asking Chris your comment on an interpretation of prominent style and so forth?
I think we've touched on many of the aspects that you just brought up there. And Aruna did present the fact that in TNT, in the high dose 80 milligram arm, triglyceride was no longer a risk factor in those individuals, suggesting that the high intensity statin was, as we just discussed, probably sufficient to remove the nastiest remnants, if we want to call them that, from the bloodstream. So it was very difficult then for further triglyceride lowering to do anything other than maybe shift the deck chairs, but not actually make a big difference to the remnant population. I have written some, just as an aside, I have written somewhere that I'm very reluctant to call VLDL cholesterol remnant cholesterol. I think we've gone down a little pathway. About a year ago, I wrote an article saying, please don't do this. If you're going to call it anything, call it TRL remnant cholesterol or TRL cholesterol, but remnant cholesterol should be preserved for the fact when we know what a remnant is, and when you can pinpoint it, say that's a remnant, and that's different from a newly secreted VLDL from a newly secreted chylomicron. Otherwise, we've actually gone down a rabbit hole and made life more difficult than it needs to be. Just call it VLDL cholesterol or TRL cholesterol and be done with it, or TRL remnant cholesterol, as we put in some of our papers. So in terms of prominent, we touched on, I think, kinetic studies about VLDL production. And most fibrate trials done by Henry Ginsberg or ourselves or others show that VLDL production isn't altered by fibrates. What you get is an accelerated push-through, which makes sense when you look at the changes in VLDL and LDL cholesterol. If you accelerate VLDL to LDL clearance, you change a particle from having a half-life of about 10 hours to a particle having a half-life of 3 days, as you said. And therefore, if you're pushing 1,000 milligrams per day in the tube, and you convert it into smaller particles with a longer half-life, then it'll go up. And a long half-life particle has much more ability to be oxidized and get somewhere. So on the one hand, I've said remnants per particle might be more atherogenic because of their makeup. By the time you get to LDL, if you're having something that lasts for 3 days, then there's plenty of opportunity for it to become damaged and become atherogenic as well. Shorter-lived LDL, as Jean-Charles said, that are larger and are cleared by remnants with a half-life of a day or so are probably less atherogenic than the long-lived. I wouldn't say not atherogenic, but there's a relative atherogenicity there between those things. So I think the answer is we've moved things around, but the atherogenic potential of what was in the bloodstream in terms of lipoproteins has not been reduced dramatically. And I think we have to accept that the prominent trial tells us a great deal about what does work and what doesn't work.
Thank you for the comment, and I'd like to ask you one more additional comment, either to Chris or Aruna. Aruna showed that in the prominent trial, or sparm alpha facilitate the transition, but the clearance was not enough. So then in that case, with high-intensity statin, sparm alpha plus like PCSK9 inhibitor will make a dramatic reduction? Do you expect that?
Yeah, I think some combination therapy is ideal. I think, as sometimes they say, you turn the key in the lock halfway, but not the entire way. If we now had something to clear the LDL particles, then I think we would get a dramatic benefit. So whenever you come along with a miracle, if it's not PCSK9 inhibition, if it's PCSK7, I don't know, but something that is cost effective as well. We do have to worry about that in this whole paradigm as we think about more aggressively treating these patients. But yeah.
Well, if I can make a comment and a question to all of you, according to what Jean-Charles said, so if you treat people with high-intensity statin, probably you've done most of your job. And the relevance of whatever is left in terms of remnants of triglyceride-rich lipoprotein is clinically debatable, at least. Now, look at the Fourier. In Fourier, 70% of people were treated with high-intensity statin therapy. On those who had evolocumab on top, the LDL cholesterol was 0.8 millimoles or 30 median, which means half of the population was below 30 milligrams or 0.8 millimoles. Yet, if you look at the patients with diabetes, after 3 years, the event rate was 10%. So, I mean, they remained. Now, my question is, if the triglyceride-rich lipoprotein role or remnants is debatable, is that extra risk due to other concomitant risk factors that are characterized in that population? Inflammation, subclinical inflammation, procoagulant state. That ties up with some of the amazing results, to a certain extent unexpected, that we saw in REDUCE-IT, for example, and clearly not related with the dyslipidemia. So that is the question, I mean, because I think clinically, we have to come out with the message for our colleagues. Our colleagues so prominent, negative. So triglyceride-rich lipoproteins, maybe they count, maybe not, but if the message is on high-intensity statin, the role of these lipoproteins in explaining residual risk is probably trivial or debatable, but the residual risk is there because these guys on 20 milligram of deciliter of LDL cholesterol have a 10% risk of events seen, not estimated. So it's there, it's a clinical problem. So either we go and use icosapentaethyl, for example, or anti-inflammatory drugs or other things to tackle the problem of residual risk in this population, or we do agree that there's still a role for these lipoproteins, actually. It's a question to all of you, because it's a crucial question from a clinical standpoint. Because the facts are that despite wiping out LDL, these people are at significant risk. Peter.
Yeah, so the world of clinical trials ranges from 3 to 7 years. And we hope from Fourier, which was actually a pretty short trial, to the universe of patients. The patient in front of me wants to live a lot longer than that. So I think we need to think about the area under the curve. And maybe if we all lived with the LDL that we're born with, atherosclerosis would be an orphan disease. So I think we need to think about the temporal course of our interventions.
Any other comment?
I would say that I think most clinicians, even most cardiologists, don't know what remnants are. When we say remnant cholesterol, they don't understand. So we have a long way to go if we go further down this path to educating.
That's okay, because we learned here that no one knows. It's a room of experts.
Right. There is clarity in the message that we also, as a group of scientists, have to project. The trial has muddied the waters. Now we try to figure out how to tell the story in a way that highlights the residual risk, that highlights that we still feel that we should be measuring triglyceride levels. I mean, there's some people saying we don't measure it at all, which I think all of us agree is incorrect. So we have to get clarity on these issues. I do think that remnant cholesterol is a valid target. I think that we we just have to get a way to clear these particles rather than just convert them.
Further comment, then I have no.
Which is, I wonder if the group of people who think more about triglycerides than I do could comment on the fate of buprenorphine, which is the antisense oligonucleotide that was studied to translate TIMI-70, I think, although I'm losing count. Although I'm losing count of the TIMI trial numbers. And although the drug did have a favorable effect, perhaps more modest than desired on the lipid profile, there were some liver findings that caused the sponsor to abandon that drug, which targets ANGPTL3. So of the in the pipeline talks that we've had today, I didn't hear about that. So I wonder if the experts here could tell us whether that's another hit on the triglyceride hypothesis, which, by the way, I have espoused loudly and clearly and perhaps mistakenly for years.
I think Jean-Charles.
So we have wonderful people here. Is it possible to extrapolate to the question why accord subpopulation with the same triglyceride HDL ratio? Why field population with a subpopulation with the same triglyceride HDL ratio are positive, totally positive? So I would like to know the comment of all my friends, and of course Peter, and perhaps many of you, perhaps you have an idea about that. We were starting with Paul, Peter, and I, and Aruna, on the fact that the subpopulation of accord and field is positive. So we will have positive results, and we did not have. So this is very interesting. It is a magical trial giving some information that we did not expect. But we have to understand. We have to understand. Is there any people here, Jorge or Bob or Marsu? How can we explain the discrepancy between subpopulation in a fibrate trial, not only accord and field, but also fibrate trial, and the fact that in prominent, with the same population, the unique difference is the level of LDL. The level of LDL is 100 in prominent, in field and accord, and 70 in prominent. So how do you explain that?
Over here, okay. You can't really. However, having discussed these things with Ian Ford, our statistician, and with the group in Oxford, like Colin Bagent, the first thing they tell you is you are not allowed to do subgroup analysis. Because when you do a subgroup analysis, you break the randomization. So within WASCOPS, for example, I can give you categorical proof that if you had a Virgo star sign, you got a much better risk reduction than if you had an Aries star sign. Categorical proof. P less than 201, but you break the blind. So the question is, when you break randomization, what confounding factors have you separated out into different groups? And what goes along with that? And the other question, of course, is the hypertriglyceridemia associated with diabetes the same as the hypertriglyceridemia that's associated with not diabetes in some of these things? Because, as we've just discussed earlier, there are very specific changes. The hypertriglyceridemia associated with not diabetes is driven maybe by C3 overproduction, whereas the hypertriglyceridemia associated with diabetes might be driven by chylomicron VLDL overproduction in the intestine. So you might be
looking at different things. But accord was diabetes, and prominent was diabetes, so at least they were in common there. But I think sometimes you have to be careful what you wish for, and we all wished that the subgroup analysis was the truth. But until we did the randomized trial, you wouldn't know the truth. And the statisticians, the prominent statisticians, would tell you that's exactly the danger of doing subgroup analysis.
I agree totally, but you know, this is a question. This is a question.
Aruna's going to tell you more.
Oh, I don't know if I can add more than what you've already said, but you know, what is different about those patients with high TG and low HDL in Accord than here 15 years later in Prominent? And I think that will hopefully shed light. It is a post-randomization analysis, so there are things that a patient who has those lipid abnormalities may be exposed to that patients who don't have those lipid abnormalities may not be exposed to in the Accord trial. So I think I'm just echoing what Chris just said. But I don't know. Okay, pass the.
Well, but another possibility is that the lower LDL and Prominent and the higher intensity statin use a surrogate for differences in the ongoing inflammation that was there. And looking at Prominent as a function of inflammatory parameters may be interesting, because maybe you reduce some of the potential benefit of an anti-inflammatory effect. And then the last thing aside, because I learned a long time ago to never ignore a question from Peter, I think that drug effect, that was drug specific, because usually when you lower trigs, the LFTs get better. You know, and so I think that was much more likely toxicity as opposed to another nail in the coffin.
Was there thrombocytosis in that one?
Yes, well, there's a concern about that. Yeah, I'd seen that.
Well, don't ignore the effects of glycemia. Accord had much higher A1Cs on entrance. And it was a 2x2x2 factorial design, which complicates, you know, the study in terms of its interpretation. So.
Just here. Thank you. Maybe it's a very basic question. Is there some minimal value of remnant lipoprotein that are required to induce atheroma? You know, if you understand the question. Because it's maybe it's not enough if the value of triglyceride is less than 400.
We have to turn here to the case of the E2 homozygote. In the population, about 2% are E22. And if you look at them, they have high remnant levels, very low LDL levels, and they don't get coronary disease particularly. Usually when you add in a hyperlipidemic trait, inherited trait, then they become frank type 3 hyperlipidemias, and they have high levels of remnants, low levels of LDL. So type 3 hyperlipidemia is a case in point that remnants are highly atherogenic. But in type 3 hyperlipidemia, the remnants that are formed are at the end of the metabolic chain, and they can't be cleared from the bloodstream. So this is a case in point where they are LDL-like molecules with lots of those things I talked about. They're very stiff. They have an altered and LDL-like mobility in the circulation. Or if you put them, Don Fredrickson used to put them on a piece of paper and run them along and stain them, and it was called floating beta disease. The VLDL had an LDL-like mobility, near LDL-like mobility. So they were basically different particles from the normal-looking VLDL, and they were called remnant dyslipidemia for that case. But take away the hyperlipidemia, and you have low levels of LDL, low levels of remnants, and you don't get disease, but you still have a disproportionate amount of remnants stroke IDL versus LDL.
But Chris, you know well that the E2 homozygotes don't get remnant accumulation unless they overproduce VLDL. I mean, they have another defect, and I think your comments really imply that.
Is it possible that just we focus on triglyceride, we focus on cholesterol, whether it's remnant or LDL? Would it be possible that when we evaluate the component related to lipids in terms of residual risk, we are looking at the wrong parameter? We're just, for example, how about if we consider whatever is the residual risk related to lipids by measuring ApoB instead of cholesterol, triglyceride, in remnants, in LDL? We measure ApoB and we basically evaluate whatever is the residual risk based on ApoB levels. Might that be a problem to simplify this complex situation?
May I add to that? But may somebody recall what the ApoB levels were in Accord or Field, at least subgroup analyses? No, I don't think. So that was it done?
Slight decrease both in both Accord and Field. Like
Decrease rather.
5-6 milligrams, but I don't remember the baseline.
Yeah. Okay.
If Jan Beren was here, he would tell you it's not only just the ApoB, it's the conformation of the ApoB that binds to the proteoglycans. So the ApoB, and this is why not having the RLP assay that was used for many years is a disaster. Because what happened is they developed an assay where they absorbed all the antibodies that bound to normal LDL, normal ApoB, and took them away. And what they were left with were antibodies that bound to B48 and to an altered B100 conformation that was present on remnant particles degraded from very large VLDL. So that was our best guess, just what you've said there, Alberto, at remnants, and I just wish we'd had that. What we really want to do is pull those particles out, and that's been done. There's papers in the literature on that, and it's mentioned in the ES consensus paper. Pull those particles out of the bloodstream and look carefully at their composition on and off fibrates, on and off statins, and try and determine, yes, the ApoB might be the glue, but what's in those particles that were prepared by those particular antibodies to see if we can find out what the atherogenic, because those are probably highly atherogenic, find out what the atherogenic components are in terms of lipids and other proteins.
Oh, thank you very much. Question, I know the numbers are small, but this venous thromboembolism signal that's come up. Dr. Yamashita showed that fibrinogen levels decreased. If anything, although the numbers are small, I wouldn't have expected that type of signal. It was a doubling of risk with hazard ratio of 2.06 or something like that. What's going on there? I mean, is there some sort of unanticipated hypercoagulable state that has been manifested through this therapy that we're not identifying? Were D-dimers measured to see if that's been fluctuating over time?
Yeah.
I'd love to hear your thoughts on that.
Very, very good thoughts. So we have measured D-dimer, have not analyzed them yet. I will say that this is what we think it was seen with PPAR alpha, the fenofibrate as well. So it's there, it's a known effect. And in those studies, there was an increase in homocysteine associated with fenofibrate, which was thought to also doubly associate with risk. And then fibrinogen levels, I believe, have gone up in some of the phase 2 data. I don't know if it's published or not, but small numbers. If it's really such a big effect in 10,000 patients, I mean, there must be something else, some other susceptibility factor. Otherwise, you'd see much higher levels of venous thromboembolism. So I think that in those patients, there probably is something we could identify that would have increased their susceptibility, whether it's prior malignancy or something else, or on top of exposure to fenofibrate to pemafibrate.
Well, thank you very much. I've been told we are over time, so I mean the discussion would go on and on forever, and it's very exciting. I think we are getting actually ready for dinner with a couple of actually answers. Is there residual cardiovascular risk? Residual questions there are not, but cardiovascular risk in certain population, even at low levels of LDL, the answer is yes. I guess the answer to the second question, what is the contribution of triglyceride-rich lipoproteins or remnant particles to this residual risk? It's open for debate, and I think will be a matter of a lot of sub-analysis in Prominent, because there are more open questions than answers. Well, let's see each other for dinner, and thank you very much for a very exciting afternoon.